All right, well, welcome everyone. We're really excited to see all of you here today for another presentation in our All About Alzheimer's series, where again, we strive to bring useful information that you can take back with you in your caregiving role or to your hospice or palliative care or respite focus or support groups work, wherever you might land in your work, that this information will be useful for you. It's a pleasure to be with you here as always. For those of you I haven't met, which I think I have met everybody here in the virtual space today, but just in case, my name is Joan Asseff and I'm a licensed clinical social worker here in the state of Texas. I also have spent most of my career working with older adults in a wide array of settings, such as skilled nursing facilities, home health, psychiatric care, hospice care, and several other settings that I won't go through today, but really enjoy that intersection of gerontology and healthcare practice. And so now I teach a clinical social work practice at the University of Texas School of Social Work, the Steve Hicks School of Social Work, as it's called now. And I've worked extensively with families and older adults and individuals going through the extreme challenges of Alzheimer's disease and other dementias. And I want to recognize the painstaking work that you do as caregivers, as people who support those living with dementia and their families. So I'm, as usual, honored and humbled to be with you today. We want everyone to know, you probably heard, we are recording this session, and we invite your participation and questions after we wrap up today's recording. So with that, we'll go ahead and get started. As usual, we have just a quick note on Alzheimer's Texas. As I'm sure many of you know, Alzheimer's Texas is an independent local nonprofit that used to be known as the Alzheimer's Association, Capital of Texas chapter. They have been privately funded and a voluntary health organization since 1982, serving the Central Texas area and serving folks with Alzheimer's disease and their caregivers. And so about 3 or 4 years ago or so, Alzheimer's Texas broke away to form their own nonprofit and decided to focus 100% of their funds and efforts here in Central Texas. However, Alzheimer's Texas maintains the same level of commitment, providing support, education, and advocacy for those affected by Alzheimer's disease and other dementias in our community, which is part of our work that we're doing today here together. All right, so what are some learning objectives that we have for our time together today? Well, we want to really recognize and consider that end-of-life decision-making is a unique personal decision for each family based on a wide range of factors. I think that's really important to remember as we go through the material for today. We want to understand the specific qualifications for and services provided by hospice and palliative care, as well as learn strategies to help families identify when it might be time to discuss palliative or hospice care with their physician and with their families. And also finally, of course, to think about and share ways we are supporting ourselves and others who are making decisions regarding end-of-life care for someone living with Alzheimer's disease or other dementias. As any good social worker and mental health practitioner and teacher, I want to remind us to take good care of ourselves today as we work through this material. Everyone has their own grief and loss and end-of-life experiences with family members and friends. Some of us have been through more challenging and more numerous experiences with death and dying, which will impact how you take in and process this information today. Please remember to put your oxygen mask on, as we say, before helping others, meaning you might need to take care of yourself emotionally before you can help someone else discuss end-of-life planning. Even those of us who've been helping professionals for many years need to take time for that self-care to make sure that we're able to support others in this decision-making process. If you need to turn your camera off or take a break in the presentation to take good care of yourself, please do so. Of course, no one will be asked to share any experiences with end-of-life care or loss, but I welcome you to share at the end of our presentation if it would be meaningful for you to do so. The most important thing for today, though, is to take really good care of yourself, as I said, as we go through this important information together. All right, so before we begin to think about making decisions regarding hospice and palliative care, it's important to understand the definitions and distinctions between these two levels of care because they're very similar in many ways, but there are some important distinctions. While hospice care and palliative care can look very similar, they are considered two very distinctive forms of care in that palliative care is a tailored treatment plan designed to improve the quality of life for patients and families with an acute or chronic illness. Under palliative care, a person's quality of life is determined by the patient and family as the priority of the care, rather than curative or aggressive treatment. This focus and treatment plan is recognized by the person or the patient's entire healthcare team, which helps carry out that focus on the quality of care. For example, a person on a palliative plan of care could decide that they no longer want to receive IV treatment because it adversely impacts their quality of life. However, they might continue taking medications orally because that still feels comfortable for them. So the plan of care can be really tailored to that quality of life measure for each individual person. The most distinct difference, the most significant difference between palliative and hospice care is that the person on the palliative plan of care can continue to receive curative and rehabilitative care, such as physical, occupational, and speech therapy, or chemotherapy or other curative or rehabilitative treatments while under that palliative plan of care. This is not the case under hospice care. Hospice care is a treatment plan designed to provide compassionate care for people in the last phases of an incurable disease, so they may live as fully and comfortably as possible. Under a hospice plan of care, all attempts to cure the person's illness are stopped and all treatment focuses solely on comfort for the most part. There are a few exceptions and I'll talk about those in just a few minutes. So, for example, treatments such as IV therapies, placement of a feeding tube, or chemotherapy are rarely provided under hospice care unless there is a clear determination that these treatments would be targeted for comfort or provided for increased comfort rather than curative in nature. And again, I'll share a little bit more about that in a few minutes. The body has a very natural process of shutting down. Just as we are born and the mother's body knows how to do that, our bodies also have a very natural process for dying and for shutting down. So many curative treatments can disrupt or interrupt the body's natural dying process and prolong a process, that process, which could lead to increased suffering for some people. This is why hospice care does not usually include these types of treatments. Most, if not all, people under hospice care also have an out-of-hospital do not resuscitate order in place, meaning they would not receive CPR if their heart stopped beating. Though I want to be clear that it's not required by most hospice agencies to be on their service. You don't have to usually have an out-of-hospital DNR or do not resuscitate to be on hospice care. Most people on hospice care have decided, or their healthcare proxies have decided, that they will no longer be hospitalized. So that's another distinction as well. Even if critical conditions arise, usually those critical conditions are treated with comfort as the focus where the patient lives, rather than trying to hospitalize that patient. Persons receiving palliative care might or might not have an out-of-hospital do not resuscitate order, and they might choose to still be hospitalized as needed. So again, some of those subtle distinctions between the two levels of care, but I think they're really important for families to be aware of as they consider these two levels of care. All right. And I want to also point out that it's important to know that a person receiving hospice care or their healthcare proxy can opt out of hospice care at any time to receive curative treatment or rehabilitative services such as physical therapy, or to be hospitalized. So I think there can be a fear amongst some patients and families that once they opt into hospice care, that they have eliminated many of their care options. And the truth is, patients and healthcare proxies can opt out of hospice care at any time if they wish to do so. And when I worked in hospice care, we routinely had worked with patients and families that, for many reasons, decided to opt out of their hospice care and receive curative treatment again. So I really want to normalize that and make sure that we're all aware of that fact. Okay, what are the qualifications for hospice care? Well, as families of those living with Alzheimer's disease and dementia make difficult decisions about whether it's time for hospice care, I, as a social worker, and I know many of you here today, know that it's really helpful to understand what those qualifications are for this level of care. The good news is that this level of care is usually fully or almost fully covered by Medicare, Medicaid, or private insurance. So most of the time, if a person has insurance, they're going to receive pretty comprehensive care and coverage for hospice services. Most of the patient's care under hospice services is consolidated under the hospice care, meaning the patient is usually no longer going to various specialists for various types of care, such as surgeons or oncologists. This would not necessarily be true for a person receiving palliative care, who might continue to see various specialists for curative or specialized treatment. To technically qualify for hospice services, a physician must write an order stating that the patient is expected to live 6 months or less if the illness runs its natural course. However, as you can imagine, doctors don't actually have a crystal ball. None of us do, and many people stay on hospice services longer than 6 months. A patient can be recertified for hospice services every 90 days for up to 180 days, so 2 cycles of care, and then every 60 days after the first 180-day period, or as designated by their private insurance. So that cycle, that frequency of cycles that I just cited is really the Medicare structure, insurance structure. So I want to be clear that if someone does not have Medicare, they'd want to consult with their insurance carrier about exactly what the cycles look like in terms of recertification. But many of them are very similar across those plans. As long as the person continues to experience and exhibit a measurable decline in condition, they can usually still qualify for this level of care. Though it's not common, sometimes people are required to discharge from hospice services because their condition has improved to the point where they no longer qualify for hospice care. I have seen this happen in my work as a hospice social worker, sometimes with people living with Alzheimer's disease or other dementias. This can happen because the person stabilizes for some reason when that stabilization wasn't initially expected. It's not, this type of care is not an exact science in terms of the physician and the hospice team being able to predict exactly, when a person might reach their end of life. And so, for example, if someone living with dementia stopped eating and then slowly began eating again, they might reach a point where they return to their baseline functioning and no longer qualified for hospice care. So again, it's not common, but it's something, it's something to be aware of, especially for Alzheimer's, those experiencing Alzheimer's disease and other dementias. This can be a bit of an emotional roller coaster ride, as you can imagine, and you might have experienced this either for yourself or with those that you're serving. as families prepare themselves to say goodbye, and then their loved one actually stabilizes and lives for quite a bit longer than expected. So I just want to recognize that that can be a very difficult experience for many families. And then I also just want to emphasize again, and I'll probably say this several times before the end of the presentation, that a person or a healthcare proxy must be willing to forego the curative treatments under this hospice level of care. All right, so as families are making these decisions, it's important for them to understand what is covered, what exactly is covered under hospice care. Hospice care includes a full interdisciplinary team working together with the patient, with the caregivers, and the family to provide needed medical, emotional, and spiritual support. So really, I have to say, over the course of my entire career, hospice care was by far the most comprehensive level of care that I saw provided for patients and families. It really was a breath of fresh air as a practitioner to see this wraparound holistic care approach. And I'm going to share more about what that looks like. All right. So it's really, like I said, the most comprehensive level of care provided really in this country. And that's because the team works seamlessly without the family having to access all of these disciplines independently. If you think about what it would take to get a patient or family member to all of these various services, it would be quite a lot of care coordination. And so it's really wonderful that all this care comes packaged together. So when a person is admitted to hospice care, their medical care is usually overseen and provided by a hospice physician. This means that most hospice patients do not remain under the care of their primary care physician for the last stages of their life. While this might seem disruptive in terms of the person's care, this shift can actually ensure that the person receives the most specialized end-of-life care from a physician trained in various comfort measures and with this practice focus. Most primary care doctors prefer for their patients to receive this kind of specialized care at end of life. This shift is also often more convenient for families who don't have to worry about transporting their loved one to a clinic or a doctor's office. In fact, all of the professionals and disciplines listed here come to the patient's home, wherever they live, which is another wonderful benefit of the hospice level of care. The RN, or the nurse case manager, really serves as the primary leader of this team, though they certainly receive and relay and carry out the physician's orders. The nurse case manager usually visits the patient more frequently than the other disciplines to make sure the person is as comfortable as possible. The frequency of visits from a nurse is tailored to the patient's needs and can vary from 1 to 2 times a week to daily as the patient approaches end of life, or what we call the active dying process towards the very end of someone's life. Under hospice care, the person also receives assistance with bathing and grooming 2 to 3 times a week from a certified nursing assistant, which can significantly reduce the care needed from caregivers and family members in the last stages of life. So that's a really important benefit for this level of care. Additionally, the family can opt to receive visits from a social worker and a spiritual advisor or a chaplain, usually anywhere from twice a month to as often as once a week, as needed or as desired. So those services are not mandated in any way, but they are certainly offered. The social worker and the chaplain can provide grief counseling for the patient and the family members, and the social worker can assist the family with accessing various community resources and completing advanced directives as needed. So there's, again, a lot of really comprehensive services provided in this really well-formed team that arrives at the patient's home with very little requests or needs or requirements from the family. Another wonderful aspect of hospice care is the fact that trained volunteers are also available to visit with the patient for socialization and to provide comfort. Hospice agencies are usually required by their regulatory agencies to train and provide patients with access to hospice volunteers. So this is an important feature for families to ask about when speaking to hospice agencies. Do they have those trained volunteers? Also, when a patient receives hospice care, many of the medications related to comfort care are covered at 100% by their insurance, meaning the person's medication cost could be significantly reduced under this benefit. Some other benefits of this level of care include periodic short-term respite care for the person in a skilled nursing facility as needed by their caregiver. This benefit can be so helpful for caregivers who reach a point of burnout or simply need a mental health break from caregiving. The respite stay can be up to 5 days in a skilled nursing facility with no charge to the family. And the hospice agency can usually help coordinate the respite stay with a facility, taking that burden off of the family. All medical supplies related to comfort care, including soft and durable medical supplies, are also covered under this benefit. And the hospice agency usually coordinates ordering and delivering the medical equipment as it's needed, which is really an incredible benefit. Often when patients would discharge from other locations, it was always challenging to know, did they get the wheelchair they needed? Did they get the walker they needed? Under hospice care, that's all taken care of. The hospice agency ensures that the medical equipment is delivered. And if it's not delivered for some reason, then the family can call that one point of contact. They can call the hospice agency and say, we didn't get the equipment that we needed. Hospice care also covers 13 months of bereavement services for family members after the patient's death, which can be so beneficial for family members who need this level of support after their loved one dies. It can be especially helpful for family members who can't afford or can't access grief counseling after their loved one has passed away. And then finally, as I mentioned, all of these services are usually covered at 100% with zero copay under Medicare and many private insurances. So we're talking about all of these services for little to no cost to the family. All right, well, where can a person receive hospice services? A bit of more good news under a very difficult topic, but again, good news that a person can receive hospice services anywhere they live. Hospice teams see patients in their homes, in independent living communities, assisted livings, memory care facilities, and personal care homes. People living in a skilled nursing facility can also receive hospice care under Medicare or private insurance if they are not receiving short-term rehabilitation services or curative care. So again, that's important to remember. If they're living in a skilled nursing facility, they cannot be, the person cannot be participating in rehabilitation services like physical therapy, occupational therapy, and receiving hospice care at the same time. And so what that means is residents who are living in the skilled nursing facility as long-term care residents, rather than under a short-term rehab stay, are eligible for the hospice care services. The hospice agency comes to the skilled nursing facility and works collaboratively with the facility staff to deliver the comfort-focused care. When I worked for many years as a director of social services in a skilled nursing facility, we often described hospice care to families as an extra layer of care on top of the care their loved one was already receiving, in an effort to provide maximum comfort and attention to that person at end of life. A person can also receive hospice care in an inpatient hospice setting. However, inpatient hospice care is only usually recommended when the person is experiencing a variety of very hard to manage symptoms that indicate they need an inpatient hospice care setting. These conditions might include sudden deterioration that requires intensive nursing intervention, maybe hourly nursing intervention, uncontrolled pain, unmanageable respiratory distress, and other conditions like those. However, most hospice care today in this country is provided in skilled nursing facilities or another outpatient or an outpatient setting, such as the home or an assisted living. And most cities, even a city as big as Austin, have few inpatient hospice care facilities today. Most of that care is provided where the patient lives and in their home setting. So it's important to also know the limitations of hospice care. While there's so many benefits associated with this level of care, there are some limitations that are really important for families to be aware of as they make their decisions. I've already mentioned that a patient cannot receive curative or rehabilitative treatment while on hospice care. I do want to mention that there are rare circumstances when hospice will cover a very limited amount of physical, occupational, and or speech therapy services for a short period of time, if these services would reduce patient pain or discomfort in some way. Again, it's very rare for hospice to cover curative or rehabilitative services, but they do occasionally do this for a short period of time. It's also very important to know that hospice care does not cover long-term care in a skilled nursing facility or any other location. These services are only covered, these long-term care services are only covered by Medicaid, veterans benefits, long-term care insurance, or a long-term care insurance policy, or private pay funds, of course, if someone is able to pay out of pocket. Hospice agencies also do not provide 24-hour care to patients, though they do have a nurse on call 24 hours a day for symptom management and for home visits as needed. I think this is a really important distinction because I think some folks sign on to hospice care with the feeling or impression that they will have 24-hour care. And while there is a lot of care provided and a lot of different disciplines coming in and out of the home, hospice is not a 24-hour care provider, though a nurse can come out if there are unmanaged symptoms or if the patient needs attention. So even though hospice is able to come out to the home 24 hours a day, families and caregivers often need additional care to meet the person's activities of daily living, safety, and or health-related needs, such as incontinence care and medication management and so forth. So those are some of the important limitations to be aware of in terms of hospice care. So how do we either help ourselves and or help others decide if it's time to consider this level of care? Well, as I said before, it's important to recognize that there are many factors that influence a person or family's decision to transition into hospice care. This is a unique personal decision for each family based on a wide range of factors. So thinking about what are those factors, we'll start out with quality of life, which is one of the most important assessments family members and people living with dementia make when considering hospice care. Quality of life is a multidimensional concept which reflects the patient's perception of the effect of their illness on their everyday physical and emotional functioning and cognitive functioning as well. With dementia or in the dementia experience, family members often make decisions regarding their loved one's quality of life based on their previously expressed wishes or the patient's previously expressed wishes and values and spirituality as well. Family members can reflect and ask themselves what their loved one would have wanted and what they might express about their care if they were able to do so. Later in the presentation, I'll provide a resource and describe it a little bit that can help families have these difficult conversations about what quality of life is meaningful and honors their loved one's wishes and values. Of course, it's very important to seek a physician's assessment and recommendation about whether the person meets hospice criteria. We might think so as a caregiver, as a family member, but ultimately, of course, the physician will be the one to make that determination and would be the one to initiate that process of admitting a person to hospice care if their family is ready, if their healthcare proxy is ready for that step. It's also really important to consider any recent changes in the person's health conditions, diagnoses, or status, and how these have impacted their quality of life over the recent months or recent years. It's also really vital to consider the person's care needs at this time, especially in light of any recent changes in condition. And ask questions about whether the caregiver is able to continue meeting those needs without hospice care or without at least an increase in care within the patient's setting. Another really helpful consideration is how hospitalizations are impacting the person living with dementia and how often the person living with dementia is going to the hospital. As many of you know, it can be helpful to ask a person's physician if they see any benefit in hospitalization, considering the patient's current condition. Going to the hospital, especially at a high frequency over and over again, can be very traumatic for people living with dementia and might be of little to no benefit in the last stages of life. Comfort-focused care under hospice services avoid these hospitalizations that can be upsetting and traumatic, especially for folks who are experiencing confusion or don't understand where they are or what's happening to them. Of course, it's also vital to consider the patient, caregiver, and family's needs for support around not just the medical needs, but also their emotional needs and spiritual needs as well. And again, the hospice team can come in and provide that grief counseling and the spiritual counseling to support those emotional and spiritual needs. And last, but certainly not least, it's important to consider the person and family's goals for care. Is curative care, such as treating infections or engaging in physical therapy, a realistic and meaningful health goal for the person at the stage of life that they are currently in and with the conditions they are currently experiencing? We can see that there are many important factors to consider, which is why many families need to take time to make these decisions. Some families will feel comfortable with transitioning quickly into hospice care, while others might need several weeks to carefully consider this option. When I worked in various healthcare settings, physicians would often want me as the social worker to facilitate the process moving along more quickly. And I would always gently push back and say that families really need that time to consider these options carefully and to have discussions. While we don't have time in this presentation today to cover all of the various assessment tools used by healthcare professionals to determine whether someone living with dementia has reached a point when hospice care is appropriate, it can be helpful for families to familiarize themselves with these tools and ask their loved one's physician to share which tools they are using to inform their decision-making around end-of-life care or hospice referrals. The Global Deterioration Scale staging system includes 3 scales that rate various levels of cognitive and physical functioning. This system has been studied extensively and proven to be reliable and valid for staging dementia in Alzheimer's disease in diverse settings, in a lot of different care settings. The clinical dementia rating is also commonly utilized for determining the overall level of health deterioration a person is experiencing. And I will cite these. They'll be available at the end of the slides for those who might want to do additional reading about these scales. And some of these may be familiar to you all who are healthcare professionals. So I want to approach the end of our presentation today by talking about some additional strategies for supporting families and making the hospice care decision. Of course, patients and families should absolutely meet with the person's primary care physician, as I mentioned before, to request their assessment and any education they can provide regarding hospice care. And at any given time, families can also request to meet with a hospice agency for a consultation. Most, if not all, hospice agencies have a designated outreach coordinator whose sole job is to meet with families, provide education on hospice services, and help them sign their loved one up for care if they ultimately decide to do so. Another really helpful step, especially if families are struggling around this decision making, is to review the person's advance directives, such as a directive to physicians or what's also called a living will. Did the person convey in writing what quality of life they would want to have? And at what point they would only want comfort care measures? So sometimes families have tools available to them within those advanced directives, or they have guidelines within those advanced directives to help them make these decisions. If the person did not complete an advance directive, it can be helpful for family members to meet and discuss what the person conveyed over the course of their lives about what they would want at end of life, and what ultimately what they might have wanted given their current health status and functioning. Even if there are advanced directives in place, meeting as a family can be, in some circumstances, very helpful in building consensus around the decision-making process for initiating hospice care. Of course, if there is family discord or conflict, these conversations can be harder, and the family might benefit from meeting together with the hospice agency and with the physician so everyone hears the same information and can ask their own questions about services. Many people considering hospice care for their loved one also benefit from speaking to others who have utilized hospice services in the past. Speaking to others who have worked with hospice can normalize the experience and give families the opportunity to ask questions about preferred hospice agencies and the benefits that their family and friends experienced when receiving hospice care. And finally, last but not least, it's really important to review the person's insurance coverage for hospice care to understand exactly what services are covered and any out-of-pocket expenses that might remain on this level of care. Now, as I mentioned, usually most of these services are fully covered. And again, as any good social worker, I'm going to direct someone to check their insurance and make sure that there's not going to be unexpected costs that they might face with this level of care. So where can we learn more about hospice care for those who would like to read more and are just beginning to learn, or maybe would appreciate a refresher in terms of the various benefits of this level of care? Here are just a few national resources that are really helpful and have a lot of great information about hospice care. I want to lift up one of these, which is the Conversation Project, which actually has a booklet with specific questions that can help families have conversations about what their loved one living with dementia would have wanted in the last stages of life. So I really like that they have a tailored questionnaire for families who are not able to really facilitate this conversation with their loved one, but are trying to facilitate it with the family as a decision-making unit, if you will. And so I highly recommend this resource for families that might be struggling with these discussions or how to get started